Google on hand, so if you ask me anything, I could just Google it quick.
Guys like you and Fritz has got Google in your minds. That's the problem. I see Fritz is here as well. Let me just admit him. Yeah, I just want to let him in. I don't know why it's sick. Anyway, Fritz is joining. Otherwise, how's it going? All right.
Cool like yours.
Yeah, we can try. I've got a good bar with it.
Now I can see, so I got to trim a little bit off the puffy side.
Fritz, is hier so?
Yes, gaan dit.
Lekker en jy?
Rustig, goed met te sien Ewart. Hallo Jonathan. How are you, man?
Hi, how's it going?
You well? Well,
yeah,
thank you.
Long time no chat.
Yeah, this year is zooming by. No pun intended.
How's the little one, Fritz?
Growing fat and taking up a lot of time.
How's it, Avi?
How's it going, guys?
Thanks so much for joining us.
No problem. Thanks for having me.
Yeah, glad you could. Listen, I think we should maybe start. Let's wait for Valdo. I think Valdo is going to join as well, and then we can start. While we're waiting for him, I spoke to Jonathan quickly today. The idea, me and Fritz and Valdo and a bunch of the other guys around here often has case discussions. And I thought maybe we'll record it and set it or put it somewhere online. We're going to definitely put it on the More Than Dentistry podcast. And the idea is just to share knowledge with each other. There's obviously a lot of cases we see that I'm uncertain of, and it'd be lucky to bounce ideas from you guys and get some input. But I think while doing it, we might as well, okay, there's Valdo. While doing it, we might as well put it online and let other young dentists see what we're doing and the way we think and the idea patterns that so that's the idea of the whole thing, and also to maybe talk about the Implant Academy. Fritz, you involved, and Jonathan's involved. How's it, Valdo? So just to kind of promote the academy as well, because I think that's a very good thing we've got in South Africa going for us, for young dentists to learn about the academy. And the whole idea of the More Than Dentistry podcast is to get young dentists to do proper evidence-based dentistry. And that's why it's lucky to have you guys here, Avi and Jonathan, to give us more of a academic input, not just a bunch of wine drinkers from the Eastern Cape that shares ideas. So
Relocated.
Relocated, yeah, of course. So the case I've got tonight that I want to discuss with you guys is an implant case. Actually, a girl that went to school with me, and she relocated to the USA, and they came down over here for lockdown. I'm going to show you the pictures quickly. She's a 38-year-old lady. Let me just share my screen quickly. Sorry. Give me 1 second. Okay, so she had I'm going to show the pan first. Can you guys see the X-ray there?
Yeah. Or we can see
Can you see the X-ray now?
No.
So
No,
you're not seeing
you've got to share that screen.
Is it not shared?
No, you have to share the new window.
But on my side, it is shared. You're sharing the screen, and it's the pan. You're not seeing the pan.
No, you're sharing the window that has all of the little images in it. You need to share the pan here.
I'm just going to redo it quickly. Sorry. While we're doing that, Avi, just introduce yourself quickly, and then Jonathan, maybe Avi, you just start quickly.
Yeah, so I'm a prosthodontist in Victoria. I practice at Capital Prosthodontics. That's my private practice. And I'm a part-time clinical supervisor at UP. Yeah, what more can I say? I'm involved with Aesthetic Academy, Implant and Aesthetic Academy. I'm on the leadership board of the ITI for South Africa. I'm on the executive committee of the Prosthodontics Academy of South Africa. So yeah, I think those are my biggest roles. I'm a KOL for most of the implant companies in the country. Yeah, I think that's about it. in a nutshell.
Awesome. Thanks so much for joining us, but I really appreciate it. And Jonathan, do you want to introduce yourself quickly as well for those around you know you?
You know, you guys know me. I'm now a periodontist from the head down, right? So not just from the neck down anymore. And an all round nice guy, right? I don't have as a fancy CV as Avi. President of my own club, chairperson of stuff that I do. Yeah, perio guy, involved in the academy. Avi and I studied together, so he's my go-to prosthodontist, and we partner on almost everything that we do together. Is joint ventures and cases and work and projects. We work very closely together.
And Fritz, do you want to introduce yourself quickly as well? Thanks, Jonathan. Thanks so much for joining us. It's lucky to have you guys here.
Cool.
Hallo, Evert. Hi, it's Fritz. I'm Fritz. I'm a dentist in private practice. I used to practice in Port Elizabeth for quite some years, and then I relocated to the Western Cape. And yeah, miss you, Kaapenaars. I miss you guys. Yeah, I mean, Waldo and Evert, our paths crossed often in the past. So yeah, I know. Anyways, yeah, so father of 4 suddenly, unexpectedly. Losing lots of sleep, yeah. So 2020 has been a great year. Twins that were born, and I can't complain. It's like
Awesome. Waldo, people on the, thanks for joining us, Fritz. Fritz is one of the most intelligent people I know. I always say to my friends, Fritz is the 3rd most intelligent person after my wife and my mother-in-law. Fritz is the 3rd most intelligent person I know. And then Waldo, I think everyone on the podcast knows Waldo, my other host of the podcast. So Waldo, thanks for joining us. It's so lucky to have a guy like Waldo around the corner. I always phone him if I need implant components or implants or bone or whatever I need. I can always phone Waldo, and he's always got stock. So lucky, Waldo, thanks for joining us. So let's get into this case quickly. I don't want to waste you guys' time for too long. Can you guys see the pan now?
Yeah.
yes.
It's on the screen. So this lady had a millisect fall on her mouth when she was, I think, 12 or 13 years old, and she lost her 1-1, and she had root canal treatment on all the other teeth, and she had a bridge in there for the past 15 or 20 years. And she said about 2 or 3 years ago, she started getting sensitivity on the 2-1 area. So so she lives in the USA, and she just moved down here for the lockdown period. Quickly go to the next photo. So we redid the root canal for her about 3 months ago. And that's what it looks like now. This is the most recent 3D I took. And she's still got sensitivity on the area. So you can see all the bone loss on the buccal, and you can see the widening periodontal ligament all around the tooth. I just took, that's the 1-1 area. As you can see, there's about no bone there. It's about 3 millimeters. And then from the 2-1 to the 1-2, there's about 4 millimeters. And I'll show the 3D properly now. That's the 1-2, and that's the 1-1. I was going to show you the other clinical pictures that I've got here. So that's the smile. That's the biggest smile I could get out of her, the biggest grin I could get out of her, actually. And that's just the pictures. And this picture I want to show you guys so you can see the kind of profile of the buccal bone there. So my biggest concern, obviously, first of all, it's a girl that I know pretty well, and we go like from primary school. I've known her, so I'm a little bit nervous to treat her. First of all, she wants to go back to the USA. She wants implants done, or whatever treatment we need to do. She wants it done now in the next 2 or 3 months. Then she's going back to the USA for about 6 months, and then they're moving back permanently. So I'm a little bit reluctant to treat her. I'm going to tell you guys what my schools of thought was initially, and then I want to test you guys' feeling, and you guys can tell me what the right way is. But initially I was thinking to to remove the 2-1 and then just do bone grafts on both areas and do a temporary bridge from the 2 to the 2. And then when she gets back to South Africa is to place a single implant. I'm going to show you the 3D quickly. Can you guys see this? Let me just go to this slice here. Open it up again. When you look at the distance between the two laterals, I don't think you're going to get 2 implants in there. If I'm just going to scroll up.
I don't think we're seeing what you're seeing, eh?
Oh, you know what are you guys seeing at the moment?
No,
Still there.
Photo.
Okay, let me
Still
just
looking
see
at the
why.
occlusal shot.
Let me just see why, sorry. Where am I now? Stop sharing. Okay, I'm going to try again quickly. Share screen.
I looked at the pictures earlier. It looks like the roots converge between the 2 anchors. Oh no, and that.
Yeah,
Okay,
can you see the 3D now?
Yeah.
So my concern is we're not going to get, well, in my opinion, I don't think we're going to get 2 implants in there from between the 2 laterals. So I was thinking maybe even doing implants on the laterals and doing a bridge from the lateral to lateral. So maybe Avi, let's start with you, and if you can just give me what you've got now. Maybe ask me questions and discuss with you what you're thinking. Where would you go with this, guys?
Yeah, I think I'm sort of siding with you. I'm worried about using that central, even for anything like a socket shield. There's no buckle bone there, so that central really bothers me. And well, this is John's call on whether that tooth is salvageable or not in terms of the socket shield. And I think it'll all pivot on that single tooth, because if that can be salvaged or even in part, then you can sneak in something behind it. And so if John's saying no there, then that means no chance. So then I'm siding with you that the next best option is, well, we know that there's not enough bone in the 2-1 site. Then yeah, it looks like a provisional bridge between laterals. And I wouldn't sacrifice those completely. There, I would definitely then do a socket shield. And you can put in an implant bridge between lateral to lateral.
Okay, so would you guys, just to put a span in the works, would you put a permanent bridge from the lateral to lateral?
No, never.
Not. Okay.
No. It's always, yeah, it's always going to fail. It may not fail in the short term, but long term, the prognosis of a lateral to lateral is highly compromised. The biomechanics of it is not good enough. Those teeth are too narrow to resist the anterior load that the centrals plus lateral should take in the protrusion. So from when you protrude, that guidance is going to keep knocking on those laterals, and the narrow neck, it's going to be prone to fracture. So I never go for a bridge from lateral to lateral unless it's splintered to something else like a central or a canine next door.
Okay, and we're all happy that Jonathan, socket shield is not an option in this case.
Yeah. So the indications for doing something like a socket shield must be that there is buckle bone, right? And here it's not even.
It's not even an option.
Nothing obvious, right? So there's trying to trim that down and keep a facial root portion. You're not achieving anything, right? So that's definitely
okay. My biggest issue is sending this patient back to USA and picking up complications. Do you guys often see patients from abroad with big implant work that you treat and then you don't sleep for the next couple of weeks or months?
Well, if she's going away for an extended period of time, and she's going to have a lot of stuff happening in her life that will preclude her from having regular dental visits, i.e. checkups, follow-ups, implants, provisionals, tissue training, it gives her time to heal. And then she I think mentally she'll also be receptive of not having access to you for a while her bone graft is healing. So it might be an ideal time to do extensive bone grafting that is going to need a couple of months to heal, and then have her back. And that just depends on what type of bone graft you want to do. You know, if you want to go classic GBR style, which is particulate bone xenograft or something else with a membrane, I would strongly advise against that, right?
Mm-hmm.
Because of the shape of the defect, because of the site, because of the position in the anterior arch, it's outside the bony envelope, and the type of shape and augmentation that you want to achieve.
Yeah.
So in my opinion, the augmentation of choice here would be a Curry bone block graft.
Plate,
Right?
yeah.
That's a block, and you three-dimensionally build everything up. That then lends you to doing a graft and doing implants quite quickly, right? So that because it's all autogenous bone, will turn into a good ridge that you can place implants in within 3 months. That's not something you really want to do, and then 6, 8, 9 months later place implants.
Okay, and then when we place the implants, would you place one implant and cantilever, or would you place 2 implants? I'm just going to show this. Avi, what do you think long term? Because this patient's still very young.
Being a central cantilever to central.
Yeah.
And what diameter implant you planning on putting in? Like 4.
Yeah, well, probably, let's just check the distance here. Probably put sorry. Just want to get to something where I can measure.
So while you're trying to get your images, I'm going to comment. I think from a didactic way of teaching and thinking, if we were having this case discussion in front of people as a study club at the academy, we would, there's kind of like didactic principles, I think, that we would emphasize, which is when you're planning a case, there's like a lot of stuff we want to look at. You want to look at a facial, this is an anterior aesthetic zone. So facial analysis, smile analysis, right? Yeah, more than likely a mock-up. What are the changes that you think you're going to make? What do you want to, and then measure out from that on your CBCT where you may or may not place implants, right? So on that CBCT, I would have positioned some virtual implants. What does the spacing look like? If I want to go for 2 implants in the centrals, what do they look like? If I rather want to do some partial extraction therapy in the laterals and do a 4-unit implant supported bridge, just, I'd play with all of those treatment options and virtually place them in the CBCT. What does it look like? What is my, what's the available bone? What's the bony envelope look like? That's, so just to bring it full circle for you, what I'm saying is, like a didactic way of thinking, following it step by step would,
going through all the steps.
Yeah.
But that's exactly what I've been doing. And then I start by doing the least invasive treatment by just taking out the 2-1. And then I realized I don't really have space for 2 implants. I've placed the implants virtually on the other x-rays. And you find that it's difficult to place 2 implants because when you look at this, I don't know if you guys can see, but when you look at the distance between the mental foramen and the buccal bone, there's also no space there. And then between lateral to lateral, there's also not a lot of space. So you're going to struggle to place 2 implants or 2 4mm implants. You'll struggle. Yes.
Yeah. I have a question, if I may.
Yeah.
If you remove the 2-1 and everything's open, would you consider removing the contents of the foramen and graft that as well? If that would maybe help in the long run to place something more, give you more options later on.
I would make that decision based again on where I would place implants in relation to planning, right? So she's got some teeth, tooth crowns in the mouth, so you can see where tooth crowns are going to be prosthetically later, more or less. And I'd try and position my implants 2-dimensionally to come out screw retained within the available bone, and then I'd start to tweak them and make decisions about what I need to add, and in this case, incisive canal, what I need to take away. Do I need to remove the contents of the canal and graft it? And so that ties in with my previous comment, that that's the type of planning that I would do. I'd place the virtual implants and then see where I can fit things, and then try the next treatment option, in the lateral sites, etc., etc. So Voldu, good point. She's got a massive canal, and maybe it does need removal and grafting.
Jonathan, how often do you do that? How often do you graft canals?
Every day. I mean, I did like 2 this morning.
Really?
Can I be honest? Never. All right. But can I foresee that, you know, if you referred me this case and said, hey, you know, here you go, sort it out. That she says, you know, finance is not an issue. She wants the best. She wants, you know, fixed option. Yeah, and we do all the surgeries she needs. You do all the ortho. That's actually what I was trying to get at. If you look at the laterals, it looks like her roots are kind of mesio inclined.
Yeah.
If she had some ortho, and I don't know what her means are, if you torque roots distally, you might create the space you need, and then you don't sacrifice her laterals for a 4-unit bridge. I don't know if you thought of that, or if that's an option.
Yeah, but do you reckon if you look at the pan, I'm going to quickly try and see if I can share the pan. Just give me 1 second.
Can I just point out quickly that you've got a ticking time bomb 2.5?
Yeah, no, we know that. We've discussed that already. Yeah. So I just want to show the pan quickly. How difficult it's going to be to correct this root using orthodontics? I mean, I think it's going to be almost upright that root.
We've got a team of guys that we work with now that we kind of mentor younger people, and luckily, whenever it comes to a question like this, we can just go, "Hey, Marvin, what do we do here?" So an orthodontist would obviously give you the appropriate answers, but I mean that's what fixed specialized ortho does. I mean they talk and twerk roots.
Yeah. So basically, that's why I've decided to contact you guys, because I'm like, the more I look at it, the more it just feels like, to me, it just looks like if you use the laterals, do socket shields and place implants and do a 4-unit fixed bridge. Yeah. Avi, what's the long-term prognosis of a thing like that?
Very good. Biomechanically, that's the best because you got balance on both sides. So you can manage your excursive movements quite nicely with that. So prosthodontically, that is the optimal result, because even if you get in a single implant with a cantilevers are not ideal. So where you can avoid them, do so. But obviously this is going to be, you know, you're going to borrow from Peter to pay Paul. So it's going to be either going for a cantilever and compromising on your biomechanics, or go for something a bit more superior biomechanically, but you'd be compromising on integrity of 2 fairly healthy teeth. So there's a bit of give and take on both options.
So that was like my school of thought as well. It's going to be the most, just to show you the picture again, it's going to be the most predictable route to, I'm going to show the smile picture.
I just want to point something out.
Yeah.
You know, if you look at the shape of the maxilla, right? So it's got and she's got quite a narrow maxilla, so it's even, you know, it's tighter like this. And also the anterior teeth kind of splay out like that, right?
Yeah.
If you try and do a socket shield in the lateral at the angles that those roots are at already, okay? And then try and get screw retained option depending on what type of implants you work with. I can't imagine that you work with external hex type implants, so internal
of
stable.
course, that's just the gold standard.
Yeah. If you try and, I mean, Avi would know, we struggled with a case of exactly like that. I submerged 2 central roots, and I did socket shield lateral, and we did a 4 units. She's still in a provisional at the moment, and it's very, very difficult trying to get your angulations right, to get them as parallel as possible, and then get them to fit nicely with the socket shields. Now, in your favor here,
point, actually.
the roots aren't doing this. But again, your virtual planning is going to tell you a lot of that.
Yeah.
What's your Fritz?
Oh shit, excuse me. Okay. Nee, wat ek gedink het, what I thought was that if you look at that, I think this is an ideal case for, can you hear me?
Yeah, we can hear.
I think this is where you would do guided surgery, because if you look distal to the apices of the roots there on the pan, it does look like there's a lot of bone if you look at the angle of the canine. So I think in terms of if you have to do something before she leaves, I also think it would be the surgery with the least amount of complications that you'd have to manage in the future. Is taking out the two laterals. You'll have good primary stability in the bone there, probably.
And then you have provisional from 3 to 3.
Yeah.
It's a big fat flipper.
No,
Flipper.
Mecca and S.
You rock any.
Let's finish that.
No. If you go to the pan and you just have a look there, distal of the apices of the laterals.
Okay, I'm just going to show that.
Yeah, I saw you got a big chunk of bone there.
Exactly. So if you use guided surgery, you can probably plan it that you cut your socket shields kind of one way, but your implants are just going to come out the same orifice at the gingival side of things, but it's going to point in a completely different direction than the roots did.
Sorry, I'm just trying to figure out why this thing is not working.
In retrospect, in that case that John and I did, I think that John, I wasn't even there for that surgery of the placement. So, John is doing some stuff with guided socket shield now, but I think that the big thing that happened with the case that's still in provisionals now that we ran into was that we couldn't predict what those multi-unit abutments would do in relation to the socket shields. And that's the big trick, because you can use angle correction. And now those things don't just correct the angle, they come out first and then bend over. So that's the tricky part. So your shield has to actually be below that level before it even, it can't even come close to the abutment, because I think our shield's cracked or something. So you need to go with enough depth to be able to get your multi-unit abutments in. So the planning is critical. It has to be with surgical precision, so to speak.
If you got your heart set on doing socket shields in the laterals, it would be great. It would be great if, there's no one who knows it better in this country than Howard, right? Once you've got your planning down to a T, pop it to him. I'm pretty sure he'll give you some feedback. But to just reflect on the case that Avi's referring to, I did do them guided, and I did the guided placement, and it was with actually Southern's has got like a drill extension and a sleeve. That was the system we used. It's probably, you could only use it here in the anterior because the componentry is so long, right? Did it work quite well? For the most part, actually, yes, right? So to follow on what Fritz said, it was guided preparation, guided placement. It went mostly very, very well. And even still, there's so many places where you can trip up. Ideally, you want your implant as close to, it's about 1.5 mil or 2 mils below the edge of your socket shield, right? So we create like a beveled shaft, and you want your implant there. You don't want your implant way down here, and this long piece of unsupported root above it, because here's implant surface, and you'll get bone apposition here, and you'll never get bone over there, right? So soft tissue will grow over it, and it's arguable whether that's an issue, right? So now we're getting very, very high grade here, but now that root is sitting within soft tissue, and if you ever press against it with your provisional or anything, you're probably going to crack it, right? It's unsupported. So that's an issue, because if you go deeper, especially if you're doing now multiple implants and you want to use an intermediate abutment to correct your angulation, whatever, bring it up to gingival level. That's what we did. We did, angled abutments. You're now going from 3 millimeters or 4 millimeters of soft tissue down to almost nothing, maybe 1 mil. You understand? So that interface is now sitting at gingival level. You can't hide it anymore. It's actually very difficult.
Yeah.
I'm not trying to discourage you. I'm just saying that there's a lot of stuff that technically can trip you up.
Baldur? Is nog daar?
Actually, I don't know. I've did a guided case today, and guided provisionals, more very similar to this. Can you guys hear me?
Yeah.
And going guided is definitely. I also had the the problem with the I also had some more bone and the root being angled, and I think it's doable doing it that way. But my case was from the 1-2 to the 2-1. Yeah, and I did 2 socket shields on those 2 teeth. So well, we didn't use multi-unit abutments. We went straight direct onto the implant.
What implants in the system, Baldur?
It was Neodents.
Okay.
And
yeah,
it worked quite well.
I mean, were you confident that you had the implants like very parallel?
Yeah, they were very parallel. I was actually amazed at that. Yeah, because they prefabbed the provisional as well, and I could fit it in. There was a little bit of tension, but I managed to get both down.
Yes, see that's a bit of an issue. Now remember that those neodents have this Morse taper, and you're taking 2 non-parallel implants, and statistically, it's literally impossible to get 2 implants, even with guided surgery, completely parallel. It's a statistical fact, given the amount of deviation you get. So the fact is that you'll have 2 non-conical, or you'll have 2 conical connections with 2 non-parallel implants, and there will be tension because they're going to be pulling in different directions. I would consider. Well, look, I think that case may be a bit easier because, as John pointed out, you're looking at a 2-1 to I think you said a central to contralateral lateral. So then the difference in angulations doesn't have to be that far different, but this case is quite different because, like John said, the anteriors play out, and you can see it on that 1-2 specifically. That 1-2 is hanging out like a bad toenail. So that whole arch is playing in very awkward direction, and once we start following where that anatomy of the bone is, those implants are going to be shooting in 2 different directions.
Jonathan?
Okay. Yeah, but can I ask you then to, if you're going to wrap this up for us, walk us through, the major steps of how you think you're going to manage this case then. I'm curious to, like, what's your thinking process now?
Obviously, my biggest concern is we're going to lose a lot of bone buccally if we take that 2-1 out. So I want to replace the bone buccally, and I want to do something that's predictable for the next 6 months to a year.
So what's your plan in the 2-1 side?
Well, the curry block would be I think the gold standard to do a bone block.
Do you want to do a bone block with the socket shields?
No. Take the tooth out completely and do a curry bone block. Yeah, I don't think that tooth is socket shieldable, if that's a word.
So
I think it's gonna go.
Did you want to do socket shields in the laterals and a bone block in the central sides?
Yeah, so I'm getting to that now. So I'm either going to do just a bone block and do a temporary and further come back in 6 months time and then do an implant and cantilever, or I then want to do a socket shield and place implants, and that's what trips me up at the moment. I don't know whether to do. If I think about doing the laterals socket shield, it just feels very invasive, and then doing a single with a cantilever just feels it's gonna fail quicker than what I wanted to fail. So I think, Avi, you're the guy to answer that question. If you got this case referred to you, what would you want ideally? I think that's going to answer.
I think I would be tripping up at the exact same decision. It's almost a moral dilemma.
Yeah.
It's you got to make the big call here. Do you take out the lady's front tooth and give her a bridge? But I do side with you. I think that if you're looking at prognosis, then I would like to prefer the bridge. I would consider sacrificing the laterals.
Can you show me photo C3 again?
Photo?
C3, please, sir.
C3.
C3.
Where was C3? There.
Between C2 and C4.
I thought that was a trick question.
Check me if you're awake. Have you opened it? Because we're just looking at your phone.
Okay. Sorry. Okay, let me just. Sorry, I'm at the wrong screen now. There's C3. Can you see it now?
Yeah. Okay. So if you look at the papillae that she's got between, obviously because she's missing the one central, so the central lateral papillae is basically gone, right? So it's like a pseudo papillae there. So it's blunted anyways. There's kind of a decent, papillae up on the mesial of the other central. So if you can recreate something like that between two implants, it would be impressive. Not impossible, but impressive. Here's my vote. Right, I'm not saying that any one treatment plan is always going to be better than another, but here's my vote. Of your treatment options, we were talking about doing socket shields in the laterals and doing a 4-unit fixed implant fixed partial denture. And another treatment option would be, I vote for ortho. Sort out, she's got some ortho problems there, right? It depends what this lady wants, right? I would go for ortho. I would talk the lateral roots out of the way. I would remove the other central. I would do a proper bone graft in that area, like a curry bone block, and really 3-dimensionally build up the ridge. Let it heal nicely, come back, place implants, soft tissue graft, provisionals, train the tissue, and save the laterals, right?
Okay.
That's what I would vote.
And you'd place 2 implants, both central to left, both implants.
Yes.
Okay.
If she's going to go that route, then full fixed orthomandible as well, because those canines are sitting right
That's
in
what
that.
That's what I'm saying. So she's got ortho issues. I'm trying to think of the whole case. I'd look at it holistically. Sort out ortho, talk the lateral roots, bone block in the centrals, 2 implants, soft tissue graft so that you can get tissue thickness and try and develop that papillae back. And she's got some blunted papillae here, and not sacrifice the laterals just yet. That's
okay, Jonathan. I want to learn. So I'm going to ask you a question.
Come back to the real world.
No, I just want to ask a question quickly. So if you decide to do ortho, right? So obviously to talk the roots on the laterals, you've got to cut the bridge into pieces.
Yeah.
But that can't be. That can't. Okay. So, and you've got the central with no bone on the outside of it. So what's going to happen to her 2 front teeth during the time that she has ortho?
There's Pontics on the wire, on the arch wire.
Pontics on the arch wire. Is that as simple as that?
I mean,
it's not very comfortable.
Yeah.
No, those things around. It's easy. It's so loose, but I mean, it's aesthetic.
Yeah.
That's all you need.
They spin around that wire.
Yeah.
I'm just asking. I mean, just from.
Yeah, it's like when they try to whistle, it's like they're at a casino and those things are spinning.
Sounds like. No, I'm just asking. It's just.
I made the assumption that you place Pontic. I mean, we've had our ortho did that for us. That put the Pontic back on the arch wire. I just assumed.
Okay, so it's as easy as that. I mean, in terms
I'm
of.
hoping so.
Valdo, just give me your opinion quickly as well. I always value Valdo's opinion highly. What do you think?
Well, I think you obviously want to take into consideration a time frame as well to give her a treatment plan. But I do think that, give her the option of the ortho. If she's really, I always just give them all the options and then give them the option that you think is going to work at the end of the day. I
don't know what's going to work.
I would probably also,
Well,
but removing that the 2-1, do a curry block there.
Yeah, that's
and
a given,
then
I think.
Temporize on the and then temporize maybe on those laterals and then see how things look when she comes back.
Here's something else. Here's another idea, and it's a bit of taking a lot from Jonathan's idea and a bit of Valdo's as well. What you could do is you could provisionalize first. So strip that whole bridge off, provisionalize 2-1 with a mesial cantilever, mesial cantilever to 1-1. Take that out of the occlusion. Provisional crown on the lateral. Then you can talk that with the ortho. So keep your provisionals in your actual central incisor with the mesial cantilever. Then you can do your ortho without worrying about the provisional phase. Once that tooth has been uprighted, then you can do your extraction and bone block, and that could work a bit better.
I just think check the bone on that tooth. If you're going to do it from it, it's going to fail very quickly.
It's a temp. You got to take the whole thing out of the occlusion. Let her function completely on the laterals.
It's going to.
Sorry, can I ask just a different question quickly? Why is this tooth failed? This is a stupid question.
That's actually a good question. I think Avi should answer that. I don't have a clue why it failed. Because the root canal looks good. The occlusion looks fine. I'm not sure why the tooth failed.
When was the original root canal done? When was the retreatment done?
I'm actually not sure. The retreatment was done about 3 months ago by me. You can see it's perfect. But the original treatment was also perfect. She doesn't have a lot of symptoms. She says it feels loose and she's got a vague pain. She just knows about it the whole time.
Yeah, but that's because there's no bone around that tooth. That's why she's having symptoms.
It will be loose.
Yeah.
Yeah.
And she's adamant to have treatment done now. She wants something sorted out.
Yeah,
I want to do nothing.
I was when we started this talk, that's what I was going to say, is if you look at what she's got, I wouldn't touch her, actually.
Why?
Yeah.
Maybe
look back. I think your endo looks pretty good. I would maybe
good,
wait for a little while.
No, I did. That's the thing. We waited like 3 months now, and the bone. I should have had the previous 3D. The bone's getting worse. It was better before I did the pan. It's getting worse.
Okay.
Yeah. Okay.
Would it help if you did a apicectomy and not retrofill, but just take off the apex and then see what happens? But
I don't think so. Jonathan, what do you think? I don't think
Yes, Waldo, I think that tooth's going to fall out if you're going to do that.
Yeah.
That's the only piece that's got bone is the apex.
No. Let's cut off the part that's in the bone. Yeah. No.
It's a great idea.
Any inflammation? No. It's probably going to be like one of those situations when if you separate the lateral from that tooth, you're going to push it up with your thumb.
That's what I'm thinking as well.
Mm-hmm.
You check. There's no inflammation. There's nothing. There's no infection. I was actually surprised she's got any symptoms on that tooth.
Look, if she's like Avi said, if she's going to have ortho and she's got an arch wire there, it's going to protect it facially, right? So if she bites on it, facial force, it'll kind of block it from coming all the way out if that's going to be an issue. But it's going to go in the bin anyways. So.
Okay, but the thing is, we're dealing with a patient living in America, basically, and to deal with an American ortho guy is going to be very difficult. So I think if she was here, it would have been a different case. How long is she here for? I think she's going back in October.
No, man. So send her for an ortho consult now. And draw up your treatment plan now. If you can get an orthodontist on board, everyone is happy. That's the ideal treatment plan. And I'm not saying that's the only way. I'm just trying to follow that direction. I know you guys are excited about the socket shield thing, and that's all good. But I'm
excited about doing nothing and just drinking more wine and not doing treatment for that. Excites me.
That's the right treatment. I concur.
Okay, guys, so let's wrap it up with we're not doing anything. We just, I'll just not phone her back. I said to her, I'm going to phone all my clever friends.
I think send her for an ortho consult ASAP. Discuss it with her. If that's the way to go, that she can absolutely get. I mean, there's a lot of good orthodontists here in South Africa, and they're probably going to charge her a fraction of what she'll pay in the US. You can get an orthodontic started now. They might have a connection in the US that can just do the follow-ups, do a bit of tweaking, replace elastics. She comes back, and then you follow the graft from the central sites.
And the reason we do the orthodontics is to get the 2-1 or the 1-2 upright.
Everything.
So we can place 2 implants. But that's what we really want to do, is get 2 implants in. Do you agree?
It's several birds, one stone. I mean, she's clearly got a medical problem here, you know. So
Yeah.
Do you have show me the photo of the smile again, please?
Okay. Just 1 second. Can you see it?
there we go.
No. There we go.
Yeah.
Look, can we be honest here? You're going to really struggle to get a very good aesthetic results here. You know.
Yep.
It's not that she
Yeah, but
has
just she's aesthetically she's happy. I mean, she's not. That's not a big thing. But yeah, I know what you're saying, and that's why I kept on thinking to go from 2 to 2, because then you can control the aesthetics a little bit more than just doing a central or doing cantilever or whatever the other plan is.
It would also probably make things look a lot nicer if you did a crown lengthening 2-3.
Yeah.
Yeah, it's a difficult case.
Right. So so I'll just not phone her. I'll just move. It's easier for me to move somewhere else.
I'm the wildest country ever.
Right. Anything else? Hello.
How can you guys?
How old is your patient? How old is your patient, David?
38 years old. She's my age. You went to school with me.
Okay. Yeah, I think she'll. Yeah, I think also will definitely benefit her a lot. I think you should sell that hard.
Guys, are you guys with me that the more implants I do, the more nervous I am of placing implants? Or like all dentistry, actually. I just don't want to do anything anymore because it just feels like everything is failing. Just depends how fast it's failing.
Yeah, that is the harsh reality of what we do, né? Is that,
Exactly.
that we help people who've already fucked up their teeth, and that's kind of my conscience is the way that I clear it for myself, right? Is that they're not at your office because they're flossing and brushing really, really well, are they? No.
She had a millisubs fall on her teeth, though, so let's help her out.
Yes, and that is the dumb luck that also, I mean, some people just have, I mean, the amount of, I've actually started dropping my business cards off at the water slide thing there by the beach because fucking every week there's a child that fractures the front tooth in twain. Okay, so there's bad luck involved also, but I mean, then what we can do is only what we can do. I think if you put that on your conscience also, I mean, I always joke with my patients, but kind of serious. I say, I'm going to treat you until you're 100. Okay? So whatever I do now is going to last on average so long. And I give them the stats. And I say that you're going to spend this much bucks on it now. When you're 50, you want to do a shitload of veneers. And in 25 years, I'm not sure if they're all going to be there still.
They will. Okay. I'm seeing them in Jeffries. They retire. Yes, Jonathan.
Just one last, I mean, I don't want to go back to the case because I'm pretty sure we got to wrap up now. But can you just show me the CVCT of the 1-2 again?
Wait, before we move on, just hang on here. I think I know why your endo failed.
My endo didn't fail. The original endo failed. I just
okay, I know why the 2-1 failed. Look at the emergence of 1-2. Look at the angulation on it, where it's coming out from and where it ends up.
Yeah.
And look at the canine below it.
Yeah.
She's riding on that lateral incisors. The anterior force, like a traumatic occlusion. It's knocking that thing off its axis like crazy.
Yeah. So when we do whatever prosthesis we do afterwards, we need to make sure it's not the same thing. That's why he's a prosthodontist and we just normal dentists. Not real doctors like my son said.
They could probably treat the lower arch with a clear aligner.
Guys, but just to be honest, like in reality, I know she's not going to go for ortho. That's honestly, I know for a fact she's not going to go for ortho. I'm not trying to put words in mouth, but in my experience, I don't think she'll go for ortho. That's what I'm worried about.
Okay.
And then I want to know, Avi, do I do a cantilever or do I do a 2-2?
We're gonna be tug of war here, but I would go 2-2.
Okay, let's stop this now. Okay, good night. Go, bye.
Good luck.
Yeah.
Okay, guys, let's wrap it up.
Okay.
I really thank you guys for joining us. I hope we can do this again, Jonathan and Avi. Fritz and Valdu, we definitely will do it again if you guys don't have an option.
Yeah.
Is there any other last comments or suggestions before we go on? Jonathan, do you still want to see the CBCT? Oh yeah.
And have you got is your passport paid up, stamped up, ready?
No, I threw the passport away after the COVID thing. I'm staying.
Okay, well.
Hashtag.
Yeah. All right. Good luck. Tough
Okay.
case.
Thanks for having
Okay,
us.
so guys, just before we wrap it up, sorry. If I'm a young dentist now that likes doing implants, what do I do with a case like this? Do I send it to my closest prosthodontist or periodontist? Who's gonna be like the quarterback of this case? Avi, what do you think? I'm in Port Elizabeth. Who do I send it to actually?
I think it's
scared. I'll be honest. You and I would be scared to take on a case like this.
Yeah.
To do it properly would be difficult.
even this case is it's I mean, there's 5 experienced guys here and it's all, making us nervous. So I think for a young dentist, the problem is we need to, not a problem, but I think the trick is we need to teach diagnosis better. So for them to be able to say, okay, this is a case that, these warning flags are going up and it's time for me to consider referral. Prosthodontist, maybe, you get many great dentists. So just because you're referring to a prosthodontist doesn't mean you're referring to someone better. I would say find a good practitioner that is experienced with case workup, with all of this stuff, and that works in a good team as well. And that's something I also stand by is a lot of people ask me if I place my own implants. And my stance on it is no, I don't want to. I can, but for me, I personally believe that if I were to my periodontist Jonathan can cut a crown, but he'll never be able to cut that crown as well as I can. And by the same token, I can place an implant, but I'll never be able to place it as well as Jonathan can. And that's what I feel, that the team is so important. And if you're going to refer to someone that's out of, if the case is out of your experience level, then find a practitioner that works in a good team where he knows where his limits are and he's happy to say, okay, actually happy to ask for help on these cases.
Jonathan, your last input?
Yeah, I mean, I'm really proud of what Avi just said. I think it's just such a testimony to how closely we work together. It's kind of like we can finish each other's
dinner.
He knows exactly what I want to say and how I'm thinking. So I echo exactly what he said. It's just interesting that, the responsibility of this case, I think any other dentist would look at it and start to just hammer out what techniques and tools they've got, which is cut back the teeth and do a long span bridge. I guarantee you there is not a dentist in this country that would turn this patient away. Not one.
Yeah.
Every single person that looked at this case would go, cool, we'll just go at an extra tooth either side, trim the tooth back. This is what a bridge is. I'm going to make you a better bridge. Boom. Guaranteed.
She'll be happy for a few years.
This someday, and they learn that, like, if all that you got is a hammer, everything looks like a nail, and that's not the way.
You guys, any last thoughts, Fritz and Valdu, before we wrap it up? You guys happy?
Yeah. Good luck.
Can I send the patient to you, Valdu?
So proud.
Guys, thanks so much for joining us. Really appreciate it, Avi and Jonathan.
Yeah.
We're going to stop it here. We'll catch up soon. The next case we'll discuss with you guys again. Thanks for joining us.
Okay.
Cheers, guys.
Thanks a lot.
Cheers.
Cheers, Jonathan. Bye.
Bye. Thanks, Avi. Thanks, Jonathan.
Groete vir die families julle.
Ja, jy verslaap jou familie al, Fritz?
My baba slaap.
Jou vrou, ander kinders.
Dis so ek. Nee, ek dink my dogtertjie slaap, my ander seun is wakker. Ek het soos 4 kinders, dis soos ek met kop hou. Ek het hulle getag in klere.
Tag in release.
Ja, nee. Almal het in hulle oor so kleur dingetjie, nou weet ek wie's wie.
Hoorie,
Vroeër vanaand het Alex van die bed af gedrop.
Ag, shame man. Hoe oud is hulle nou?
Ja.
Ek weet nie vir die video.
Hulle is 26 Januarie gebore.